Well, hi everyone. Like Lewis said, I'm John Kachoris. I'm a neurologist. I'm with the neurology group River Hills, which is a private practice neurology practice here in Cincinnati. I've been with them for, 10, 11 years. In the last 2 years, I pretty much am full-time over at Jewish Hospital doing these two things: Director of Neurocritical Care and Director of Neuroscience Education. As we'll talk about sort of at the end, Jewish has big plans for neurology in Cincinnati. And my training is in, as it says, neurocritical care, which means I did a fellowship after my neurology residency in neurocritical care, which is ICU neurology. Stroke doesn't all end up in the ICU, but certainly some of it does. And as I said, we'll talk about at the end why Jewish has brought me on and what we're doing over there when it comes to stroke and just a lot of the real significant, serious neurology. So we'll come back to that. So that's me. Just as a formality, I've done a couple of paid talks for these companies on migraine medicines, not really anything to do with what we're talking about today. So here's kind of the gist of what we're going to do. First of all, we're just going to answer the question, well, what is a stroke and a TIA, right? I'm sure you've heard of both terms, and there's some confusion, even amongst medical people. What is really the difference between the two? What is the pathophysiology of stroke? In other words, what's gone wrong that's causing a stroke? Why do those things happen? Then we're going to look at some of the signs and symptoms of stroke, and a lot of the handouts that you've already picked up really kind of hone in on the things we really want the public, really all medical people, to be honest, to be aware of, what to look for stroke. Some of it people know very well, and there's a couple of things that are a little bit not so obvious. And again, even in the world of medicine, for non-neurologists, there are a lot of stroke gets missed because some of the symptoms can be a lot more subtle. So we'll get into that. We're going to look at what the hospital system model is for stroke care. So primarily we're talking about from when you call 911, what happens? Where do you go and why? Cincinnati has its own model that is modeled on what the Heart Association recommends, and it's kind of the gist of what everybody's trying to do nationwide in terms of getting people to the right places for their strokes. And then once you're in the hospital, both in the emergency room and admitted, what do we do? What do we do to fix you or help prevent you from having more stroke in the future? And then what you all can do as individuals for yourselves and obviously for your loved ones too, to help prevent stroke in the first place. As we'll get into here right away, stroke is not reversible. People that recover from stroke, it's because good brain kind of took over for what was lost by the brain that's dead. And once brain is gone, it's gone. So the best way to get better from a stroke is not have one in the first place. So we're going to look at some of that. And then, as I mentioned already, kind of the future, where Jewish Hospital in particular is going in terms of stroke care and a lot of their more emergent and serious neurologic care. So, back to the beginning, what is a stroke? Very simply, it's a blockage of blood flow to some part of the brain. Whatever part of the brain then doesn't get blood dies. And as I just mentioned, when it's gone, it's gone. So when you've lost it, the only way you're recovering is, again, because the good brain around it learns a new thing, kind of takes over for what is lost. It's different than when you cut yourself and your skin will heal good as new, or a bone breaks and heals good as new. The brain cannot do that. But the brain can adapt. We call it neuroplasticity, and it can take on a new role. That's sort of like skin becoming bone, right? That doesn't happen elsewhere in the body, but in the brain, that's the way it handles it. So essentially just some statistics. Ischemic stroke is the kind we're talking about when we say that there's been a blockage of blood flow, right? Ischemia means a lack of oxygen. So as you can see, 80 to 85% of all strokes that happen are this blockage of blood flow. And like I said, then that brain tissue dies. This is the leading cause of disability. The thing I tell patients all the time is that stroke will not kill you. If you die from stroke, it's because of all the complications that ensue. It's not like having a big heart attack and they don't are able to revive you and then you're gone, right? So stroke is no way to go out. You know, people who say, I've lived long enough, I'm fine, if it's my time, it's my time. You don't want to go this way though. This is not fun. So it's the leading cause of severe disability worldwide. And then for our purposes, and I'll go through this, but this isn't really important for you to remember, we talk about strokes based on the vessel that the blockage occurs in, as well as the mechanism that caused the blockage, right? So those first two, where it says large vessel thrombotic strokes and small vessel thrombotic strokes, thrombotic really implies that that's plaque that's built up in the vessel. And then that plaque can accumulate to the point where it blocks the blood flow, and then there's your stroke, right? So we can see that happen in the smaller blood vessels, kind of out in the periphery or deeper in the brain, and also due to, it happens in the bigger vessels, which then, as you might imagine, is going to give you probably a bigger stroke and involve more brain. The other two then, the atheroembolic strokes or the cardioembolic strokes, an embolism is a clot that travels from somewhere, plugs the blood vessel up like a cork. And so atheroembolic implies that there's plaque somewhere that traveled further into the brain and plugged the blood vessel up. And then there's the cardioembolic stroke, implies that it's a clot that came from the heart and traveled up into the brain and caused the stroke. Incidentally, the number one cause of cardioembolic strokes is an irregular heart rhythm called atrial fibrillation. So if you've heard of that, or have it, or know someone who does, in all likelihood, that person's on a blood thinner. And a blood thinner works to keep the clots from forming in the heart, so therefore you don't get the stroke. Cardiologists will certainly use other medications to try to control the AFib, atrial fibrillation, but that's not foolproof. So even if they think they've got it controlled, all it takes is a short bit of atrial fibrillation to cause a clot, which can then cause a stroke. And that's why, for the most part, people who have atrial fibrillation, regardless of what other treatment they're getting for it, also need to be on a blood thinner to avoid these cardioembolic strokes. As you might imagine, these emboli, clots that travel from somewhere and plug it up like a cork, those tend to be bigger strokes, right? Clots like that tend to be very big. And so those tend to cause the more devastating strokes. But all of them, and I'll mention this part right now too, people always ask me after they've had a stroke, well, is it a big stroke? Well, the stroke is as big as what it does to you, because the brain is like real estate, right? It's all about location, location, location. So you can have a very small stroke in a very eloquent or important area, and that can be lights out. You can have a very big stroke in another area, and it doesn't really necessarily do a lot of outward change. So that's why I say it's like real estate, because some strokes are like, you know, the cost of a penthouse in Manhattan for a very small amount of land, whereas other strokes are like a huge ranch in the middle of Idaho, where, you know, you can get acres and acres for a song, and so it's not as desirable, right? So same idea. Okay, so when we talk about stroke risk factors in general, especially the ones that cause the plaque buildup, right? That's what we call vascular disease. So when you hear vascular disease or atherosclerosis or hardening of the arteries or plaque, that's pretty much all the same stuff. And so these things listed here are we know to be the risk factors for having a stroke or also a TIA, which we'll come to in a minute. And as you can see, these aren't in any particular order other than the first one. The biggest risk for having a stroke is having had a stroke. So in other words, I tell people that if someone's got a stroke, if they have an identical twin who's exactly the same as them in every respect, all the risk factors, every single molecule is the same, the twin with the stroke has a much higher risk than their other twin for having another one. Because it kind of it's sort of logical, right? If you're already for some reason a setup to have it, then you're probably a setup to have another. So then these other things, the hypertension, diabetes, hyperlipidemia, which is high cholesterol, smoking, those are all things that we can control or can be controlled. Having them still increases your risk for stroke than not having them ever. But having them controlled is certainly the best thing that we can do to help prevent that plaque buildup. The other one, coronary artery disease, that's really a misnomer in the sense that a coronary artery disease is due to vascular disease, right? So essentially, it's the same thing as the plaque that can build up and cause a stroke is the same idea as the plaque that's building up in the vessels of the heart and can cause a heart attack. So coronary artery disease, having it implies that you've got some degree of vascular disease then if you have that problem. But the coronary artery disease itself is not the risk for the stroke. It's the vessel disease that's the risk. Alcohol, obesity, inactive lifestyle, those are certainly contributors. But if you show me somebody who has none of this other stuff and they just like to sit on the couch and watch Netflix all day, or they're a little overweight, I'm not saying that that's the reason then that you had a stroke, right? In and of itself, that's not enough. It usually plays a role in the other things, right? So certainly people who are obese tend to have high blood pressure, diabetes, and high cholesterol, and so therefore they are contributory, but they're not really primary risk factors the same way those first 1, 2, 3, 4, 5 are. And then family history and age, the way I usually tell it to people in the hospital is there's 6 reasons why you're going to have vascular disease. 2 we can't do anything about, 4 we can. The 4 are the high blood pressure, diabetes, cholesterol, and smoking. And these 2 are age and luck, right? Some people are just more prone to vascular disease than others, no matter how healthy they are. Sometimes these are the stories you hear about, Olympic athletes or people who are in the best shape of their lives dropping dead from a heart attack, and it turns out they had horrible coronary artery disease and nobody ever knew it. That's just inherited. That's just bad luck. And age, everything gets worse as we get older. Everything starts to break down. The plaque builds up no matter what. There's just a lot of wear and tear on the vessels, and they get into trouble, and we can't do anything about that yet, at least. The other thing too for family history is so when people tell me oh yeah, there's a lot of strokes, people in my family had strokes really early or heart attacks really early in life, that is usually because they have inherited or they have a risk for the vascular disease. They didn't inherit the heart attack, they inherited the vascular disease, which then caused the stroke or the heart attack. So that's the gist there. Now, this talk, we're not going to get into a lot. You guys, please, anytime also, anyone ask me any questions you have, and we'll certainly have time at the end for that as well. We're not going to get into all the nitty-gritty with exactly the numbers and how to control all of these things. That's really, as I say as a neurologist, my job is to figure out which of these things contributed or caused your stroke. Then I pawn it off to the primary care doctor to fix all that stuff, right? So, and as you can tell, blood pressure, diabetes, cholesterol, that's bread and butter internal medicine stuff. So that's the reason why we say we really should go to the doctor every year, because no matter how we're feeling, because those things are all the silent killers, right? You can have all of those out of control and you would never know it until you have your stroke, and that's your first sign that all that stuff is out of control. So that's the best thing you can do to help, in addition to knowing about it, but helping really control any of those risk factors or finding them in the first place. So we talked about the first 80% or so of stroke. The other 20% are this kind. We call hemorrhagic strokes or bleeding strokes, right? This is a little bit, it is a lot different the way in terms of how we manage it and what we do in the hospital. It is completely different. It's almost 180 different from what we do for the other strokes that we were just talking about, and really is the main focus here. The bleeding strokes are literally where the blood vessel ruptures. The number one cause of that is high blood pressure. And it is usually blood pressure that's really overall not well controlled at all. So we're not talking about people that, now you can see it though, so don't get me wrong. It's important for this as well as the strokes, as well as heart attacks, vascular disease. But we're talking about people who, normally live with a blood pressure like 190 over something, right? Higher than that even. And that will definitely cause bleeds. And those bleeds tend to be in a very characteristic spot. So when we see a CAT scan that shows blood, if it's in that characteristic spot, the first thing I do is go look at their blood pressure, because that is the number one cause of these kinds of strokes. Aneurysms, A ruptured aneurysm, again, is an entirely different beast completely. Yes, that's causing bleeding, and yes, that is technically a stroke, but the locations are very different, the symptoms are very different, how we manage it is very different. So that's certainly a cause of stroke, hemorrhagic stroke, but not really the most typical of the hemorrhagic strokes. Arterial venous malformations, as we call them AVMs, this is essentially, as it sounds, it's some kind of malformation between the arteries and the veins. So the arteries going in, the veins coming out, and there's a communication between them that shouldn't be there, and it's weak, and sometimes that can rupture. And then brain tumors will certainly bleed sometimes, and it can sometimes be the first presentation of the tumor. So aside from controlling things like hypertension, all those vascular risk factors, it's really all you can do to prevent having a hemorrhagic stroke. And the management, like I said, is very different. Sometimes they go to the OR to get the blood drained out. So most of the times it's just a matter of watching them and supporting them through it until literally that blood can heal like a bruise, like any bruise does. And the deficits or the problems that they're left with afterwards will depend on, again, just like with the other kind of stroke, where did it occur, how much damage did it do. The one advantage, maybe you want to call it that, with the bleeding kind is that as the blood goes away, the function gets better because the blood doesn't necessarily kill all of that brain. It just irritates it. So as that irritation goes away, as the blood goes away, people can do much better than they looked in the beginning. But then there's still the leftover damage piece, and then it's just recovery like the other kind of strokes too, which, like I said, is all about good brain learning a new thing. So that's the bleeding ones. So now, what is a TIA? So it stands for transient ischemic attack. So we already know what ischemia means because we talked about that. That's a lack of oxygen, right? So a transient ischemic attack is a lack of oxygen that comes and goes. And that's how I tell people it's a stroke that comes and goes. We don't like the term mini stroke. That's usually a very common thing that people will either have picked up on their own or even be told by their doctors that they had a mini stroke. The reason I don't like it is because it downplays its importance, right? There's really nothing mini about it. You can probably already understand, based on what I've already said, that the two things are the same, right? You had a blockage of blood flow. In the case of a stroke, that flow didn't open back up, so the brain died, and you're stuck like that. In a TIA, the blood flow actually is restored before damage can be done, and so the symptoms go away. And when we look on a scan, we see no damage, because that's the definition of it. It didn't do any damage. But the problem is that why it happened in the first place is exactly the same. It still happened. And so we take these very, very seriously. And so that's why I don't like the term mini stroke, because it kind of implies like, no big deal. No, it's actually, if you think about it, it could be sort of, the shot across the bow that you're heading into troubled waters. That's the time to act before you actually have the stroke, and then there's nothing we can do about that. So the TIA is really, in some ways, even more scary than the stroke itself, because it's a sign of something that's to come, potentially. So, as I mentioned, these are symptoms that resolve in minutes to hours. The kind of textbook definition, so you might hear doctors say this, is that they're symptoms that come and go within 24 hours. That's not the accepted definition. The definition is minutes to hours tops. And if you think about it, it's sort of obvious, because if you have a lack of blood flow for 24 hours, odds are you've had a stroke, right? Even if your symptoms get better, by the time we do an MRI scan, we're going to see the stroke. And you may be better, and that's fantastic. That just means the body, the brain, was able to rally fast enough to kind of take over what was lost, such that you don't have any symptoms anymore, but you still had damage done. Again, based on what I just said, I don't really care. If you had a stroke and we see it on the scan, or you had a TIA and it happened to last longer, and it doesn't matter. We know that something happened. You had blockage of blood flow, and we got to figure out why, and we got to fix that so you don't have any more. As I was sort of alluding to already, having that TIA is, again, that sort of shot across the bow, right? That's when we worry about something is to come. The highest risk of having another one or stroke is within the first week, and it stays very high for the first 30 days. There are scales that they will use in the emergency room to sort of assess what the symptoms were, how long things lasted, stuff like that, to sort of give you a ballpark number as to what is the likelihood that you're going to have another one in 7 days or a month, and then sort of base recommendations on that. Again, I'm not a big fan of that because, you know, we are not statistics, right? It may be true that for the population, the odds of me having that stroke in the next 7 days is 30%, but that doesn't mean that it's 30% for me. It may be more, right? So, and those kinds of scales make me a little nervous with something like this that can be so devastating, and, you know, with except for a very narrow window of opportunity, there's very little that we can do about it. So the point is, don't ignore it, right? So I have it many countless of times. Someone will have symptoms. Either they will call 911, the family will call 911, the paramedics arrive, they say, we got to take you to the hospital, we got to make sure you're okay. No, I'm fine, I don't need to go. Don't do that. Don't ever do that. Because when you call the next time, it's going to be for the big one. And so please, if you have symptoms, as we'll get into, don't ignore them. Please come to the hospital. We see the things much more frivolous than any of these kind of symptoms in the hospital, the emergency room, all the time. So we're more than happy to, you know, give you that clean bill of health if it looks like it's not, actually wasn't a TIA or stroke. Okay, so now getting into sort of some more of this mechanism, what's going on here. So as you can see by the little cartoon, this is representing an artery with plaque all built up in it. And then it's suggesting that the blood flow here has been interrupted, or in some cases blocked completely. And then therefore this is to represent the area of the brain that's now not getting any. And that's the part that dies pretty quick. Within 4 to 6 minutes, brain starts dying. As I said, so these die pretty quickly, and we call that the core. And that's where the immediate brain damage or nerve injury is occurring. Then there's this area, so let me orient you here. You're looking straight on at this face. And right here, we have a big artery called the carotid artery coming up. And this is representing that you've got your core right here, right? So we block this blood vessel. And so blood is not getting to that area for sure. But then we have these vessels coming up. We call those collaterals, right? So it's blood supply that's kind of getting around it. It's like taking 275, you know, around the traffic jam. And then the penumbra here this is the area that's at risk. It's not getting enough blood. It's not dead, not yet, but it's not getting enough blood. And so sometimes the symptoms we see outwardly will include all of this brain, although this is the only part that's dead. So there is still something, hopefully, that we can do about that to restore that blood flow so that we salvage this part before it dies, and then the person will get a lot better. Almost turning it into a TIA, right? Because now you open that flow back up. And we call that, like I mentioned already, that's the penumbra. And so some of our interventions that we'll get into are the things that we have that can, you know, literally save that. We'll come back to this picture later, but this is how that core and penumbra look on a CAT scan. So the areas that you see in purple, this half of the screen, these are the areas that are not getting enough blood flow to be compatible with survival, right? This purple. The other side, the green, that's the penumbra, right? So as you can see in this particular case, the core is pretty big, but the penumbra is even bigger. And the person is probably suffering symptoms on the outside that involve all of that green area, right? If we can open it back up, we can't fix this, right? So whatever this was causing is still going to be there. But whatever this additional was causing, we can potentially get them better. Yes?
Well, is there a time thing on
Yes.
it?
We'll come up to all that stuff, yeah. So I just wanted you to get a sense right now of how it looks, how do we like assess for that penumbra core thing. So that's how we do it. This is called a CT perfusion scan, by the way. Well, again, we'll come back into all this in a little while. Okay, so not to overwhelm everybody with a major neuroanatomy lesson, but just so you have some concepts, because this is important when it comes to stroke symptoms, and in addition, stroke symptoms that are missed, because they're not the typical ones. Essentially what we're looking at here is that this is obviously the front of the body, and this right here is the carotid artery going straight up the neck. And then back here you can see we also have something called the vertebral artery, right? So we have two carotids in the front and two vertebrals in the back. So all four of these vessels feed the blood to the head. The carotid artery, there's a lot of squiggles here to follow, but essentially the carotid artery is feeding what we call the anterior circulation. It's feeding all this, right? Over there. It's feeding all this. The vertebral arteries are coming up and they're feeding this. And that's what we call the posterior circulation. Strokes that happen here, which is a majority of them, probably about 80% of strokes, happen in the anterior circulation. And those are the ones that have a lot of the symptoms people think about when they think of stroke. Their face is droopy, they're paralyzed on one side, they can't talk, things like that. The posterior circulation strokes are very different symptoms entirely. And these are the ones that are missed, in part because they also, other conditions can cause similar symptoms, and so they get ignored, again, by patients as well as doctors. And that's one of the big pushes that the Heart Association is making these days in trying to make people more aware of all of these other symptoms in addition to the ones everybody thinks about already. So we'll come back to that. Essentially, this is the same thing, but it's kind of zooming in on this posterior circulation section right here. So again, this is that vertebral artery, and it comes up and forms this big artery called the basilar artery, which goes along the base of the brain. And it's feeding primarily this thing called the brain stem. As you can see, the brain stem, where it goes off the page here, that's because it becomes the spinal cord. So everything that goes in and out of the brain has to go through the brain stem. I liken it to the fuse box of your house. So this is back to my location. A small stroke in this area can do a lot of damage, because and the brainstem's not much bigger than your own thumb. So if everything is passing in and out of that, and you have a stroke in part of it, like I said, it's like taking a hammer and smashing it right into your fuse box. You're gonna lose a big section of the house. And so this will be important in a minute when we see some other slides, so that's why this posterior artery, this basilar artery, is really important. And it's big, and sometimes you'll get clots in there. Like I said, the clots that travel and plug it like a cork, sometimes they'll go there, and that can be really devastating. And then in addition, as you can see, as that blood flow goes up, it feeds this back part of the brain called the cerebellum, which is responsible for balance and coordination. It's the first part of the brain that gets affected by alcohol. That's why some of the tests we do on patients to see how their cerebellum is working are the same tests that the cops do as sobriety tests on the side of the road, because they're doing a neurologic exam essentially to look to see how the cerebellum is working. And then what's not shown here, but is up here again, is all these vessels go back to this back part of the brain called the occipital lobe. And the occipital lobe is responsible for vision, right? So you can kind of already see where I'm going with this when I talk about how the symptoms of stroke can be missed, because lots of things can cause difficulty with balance and with vision. Okay, so as I was saying already, if 80% of the strokes are happening here in the front, then 20% are happening back here in this posterior circulation. So 20% of the strokes have a higher incidence of getting missed, because the symptoms are a little bit more unique. This picture is essentially showing, again, now we're looking straight on at the person, and the purpose of this one is to tell you that, as I mentioned, this is that basilar artery, the BA, there are times when you have big clots, they tend to go to certain spots. And again, it's because they're going to be too big to go down deeper into the smaller vessels. So they get stuck where these big vessels start to branch or narrow, right? So we can have a big clot here in the back. This is the internal carotid artery, and you can have one there. And you can see it's going to affect the flow downstream from everything else, right? From that point. So a stroke in the carotid artery can affect that whole hemisphere. Whereas if it makes it a little bit further to this where it says M1, this branch of this artery, well then you're going to affect this, but kind of spare that. And if it gets even further, then you're going to get maybe more of this, but spare all of this. You see it? So it's like literally like a tree with the branches. And the further up the tree you go, the smaller and smaller the branches get. So however big a clot is, it's going to get stuck at some point in that tree. The bigger it is, then the bigger the branch that's going to be involved. And we call those large vessel occlusions, LVOs, right? It's just as it sounds. It's a large vessel that's been occluded. And the reason why I bring that up is because this is where our technology has advanced. We're just within the last 4 or 5 years, really, to be able to do something about those. Those strokes that are the most devastating, we can actually do something really, really good with nowadays that we couldn't before. So we'll talk about that. So as you can see, it's quite a weird range, but 15 to 40% of strokes, and that's either a lot or a handful. I'd say in practice, it's a lot. We tend to see them pretty frequently, are going to be these large vessel occlusions. Okay, so these are the symptoms that most people are aware of when they think of stroke. And this is called, it's not called the Cincinnati Pre-Hospital Stroke Scale just because we are in Cincinnati. It is called that because it was developed in Cincinnati. So all over the world, it's called the Cincinnati Pre-Hospital Stroke Scale. The reason why it exists is because the roots of stroke care, acute stroke care, all start in Cincinnati. So back in the, I'd say, late 80s, early 90s, there was a trial that was funded by the National Institute of Health, and it was led by some neurologists over at UC, right here, UC, and it was the studies that developed and proved that TPA, which is the clot buster medicine that people have probably heard of, those studies were all done here in Cincinnati. That standard of care, that treatment that's the standard of care worldwide, was all done right here. And that was the birth of the stroke team, which is, if you've heard of it or not, it is unique to Cincinnati. What it is it's a group now of neurologists and emergency medicine doctors, a whole fleet of nurses, nurse practitioners, and they are on call for all acute stroke that happens anywhere in Cincinnati and northern Kentucky. Now with the age of telemedicine, they are covering a huge area. Any of those places, any of those hospitals, including at Jewish, has a stroke, come in. The first call that's made is to the stroke center, the stroke team. And that doctor who's on call gets on the little iPad to actually look at the patient themselves, but works with the doctor, is able to look at all the pictures, all the imaging remotely, and help make a decision on how they're going to treat that patient. So every stroke in the Cincinnati area is getting the expertise around the clock of not just a neurologist, but someone who specializes in stroke. That is very unique to Cincinnati. Other cities, I'm from Chicago originally, that's where I trained. I actually came to Cincinnati to do my fellowship because of the powerhouse that UC is when it comes to neurology, especially the stroke team. In Chicago, and again, certainly in smaller cities than that, we were responsible for all our strokes within our 4 walls, right? So if a stroke happened in our hospital, there was no call out to the wild. The call was made right there in that building. Obviously, as a neurology resident, there were neurologists there because we were at a big academic center. So we certainly knew what we were doing. But if you were at the hospital down the street, there was no one to call. It was the emergency room and the internist and whoever was on call, who's not necessarily trained in neurology or vascular neurology, would then handle that stroke. And so to have this in Cincinnati, and it's existing still from way back then when they started the study, and they've just kept it going all this time, is really a bonus for all of us. The reason it even formed is because when they were doing the study, the doctors who were saying, we think this TPA stuff could actually open blood vessels up. And so in order to get that to go, the hospitals would call them, and they would get in their cars with the TPA like in the car, and they would drive to the hospital, and they would assess the patient, and they would decide, is this person going to get the medicine? And of course it was randomized, meaning some people actually got the TPA and some people didn't. They got some, saline or something else. And very quickly, as they started gathering this data, they realized that strokes could be reversed, or stopped, I should say, in their tracks, open up that core, save that penumbra, by administering this medication. And so therefore, as part of their scale, in order to assess patients, is this a stroke or not? Is this worth giving the treatment or not? They developed this scale. And like I said, that's why this scale still exists today. And essentially, so looking for someone's facial droop, do they have a weakness? Usually the arm tends to be affected more than the leg, and it's a lot more obvious usually too. So it is a good symptom or sign to look for. And then the abnormal speech. Quickly, I'll tell you that that's checking two things at the same time. It's checking speech and language. Speech and language are not the same thing. Speech is how it sounds. So if I have a slurred speech, it's because if I have weakness in my face, like that guy, then it's not going to sound right when I talk. That's speech. That's slurred speech, or what we call dysarthria. Language is different. So if you have someone read that sentence and they say it, you can't teach an old dog new tricks, well, okay, that's your speech is affected because of muscle weakness. But if you say it to me and I just stare at you, and I might say a word or two, that's language. That's my inability to use English, right? Essentially, we call that aphasia, where the language area is affected, and now my ability to use English is gone. So it's the same concept as if I asked you to start speaking to me in Spanish and you don't speak Spanish. You know what you want to say, but you can't get it to come out in Spanish. It's the same idea. So that sentence is essentially checking two components that go along with, that can happen with stroke. Okay, so that's that. But as I said, that's lacking. That's not going to check or find all the things that we worry about when we're worried about someone having had a stroke. So this is, if there's one take-home point in terms of what are the stroke symptoms to look for, this is it. And that's what you have. There's cards over there. There's all kinds of stuff with this Be Fast thing on it. This was developed by the Heart Association. And it used to be just the fast part. The B was added because of these posterior circulation strokes that were getting missed. So essentially, going through it kind of quickly, B is for balance, right? And as I said, that back part of the brain is responsible for balance and coordination. Now, lots of things, as we even said, that's the first part of the brain that gets affected by alcohol. So is somebody drunk, or are they having a stroke? There's a lot more than that goes into it, but this is why sometimes these strokes can be missed, because someone says, oh, they're just drunk. You could be both, right? They could have a high alcohol level and, oh, whoops, it turns out they actually did have stroke too. So it takes a lot of nuance to really tease these things apart. The other thing that goes with balance is not, so the way people in general, again, medical people too, I get it all the time. Some medical resident will say, hey doc, we have a patient we need you to see who's dizzy. What does dizzy mean, right? Dizzy can be lots of different things. That doesn't tell me anything. Because to me, dizzy is either off balance, right? Can't walk a straight line. It's either vertigo, where it feels like everything is spinning around in a circle, or it's lightheaded. Ooh, I stood up too fast, I think I'm gonna pass out. That one, we call syncope, is more likely a blood pressure problem. Again, you stand up too fast, your heart can't respond quick enough, your blood vessels don't tighten fast enough, and the blood pools to your feet, and then you feel it. And some people actually go down. That's not a stroke. But the vertigo and the balance, because we already talked about that, can be these posterior circulation symptoms. So the vertigo piece, that spinning piece, sometimes the brainstem can be responsible for that kind of symptom. So again, but people can have vertigo. You hear people say all the time, oh, I've got vertigo. I had another episode of vertigo. So how do you know? Well, we don't really know until we really do all the scans and all the testing. People who have had vertigo before and they have a similar episode doesn't mean they need to all rush off to the emergency room because now this time it's a stroke. But at the same time, if you're having new episodes of that kind of spinning feeling and it's not going away, then that certainly warrants being looked at. That could be a stroke. Then for the eyes part, as I also mentioned, that occipital lobe back here is responsible for processing vision. So if you have a stroke there, it's going to affect your vision because as the light comes in, that's working, makes it to the back of the brain, but then there's nothing there working to process the signal. And so the person will lose that area of vision. But it's not like they necessarily see blackness, right? If I cover my eye, I know it's covered because it's dark. But this part, when it's broken, just isn't working at all. It just doesn't process anything. So it's not like it sees black, it just goes away. So your field of vision can get very narrow, right? And sometimes people won't really realize that. Like, something's wrong. Like, I'm crashing into things as I'm walking on this side. It's like, well, yeah, because they've lost their peripheral vision and they're not even aware that it's missing. Certainly you can have a stroke a clot that goes right to the eyeball itself and then take away vision, and that is going to be dark, where they cover up their right eye and they say, yeah, it's all black, I can't see anything. So that is part of it too. So any sudden changes in vision outside of, it's a little blurry, I think I need new glasses, like sudden things that are new are potentially stroke too. And then the rest of it is, as we've already talked about, the droopy face, the weak arm, the speech and language, and then the T is for time, which, as you'll probably already guessed, in order to do some of these therapies, as we'll talk about in a minute, time is of the essence, and we'll get into that a little bit in a minute. So as soon as you think it, you call 911. If the symptoms go away, you still get in the ambulance and you go. You don't say, oh, I'm fine now, I'll just call my doctor tomorrow. That happens a lot. And then the doctor says, go to the hospital right now, but it's over, it was yesterday, go to the hospital right now. So this, I'm not going to go through all the details, but this is called the Cincinnati Stroke Triage Assessment Tool, not because it's invented in Cincinnati, unfortunately. This is just because this is what each EMS system pretty much uses this. This is the one that comes from our EMS system, so it's called Cincinnati, but Cincinnati can't take the claim for this one. Essentially, the reason I put this up here, though, is that because we have these large vessel occlusions, as I mentioned, which can cause these really big strokes, those symptoms tend to be much more profound. And so they have a special scale that the paramedics do to look at these things in particular, because if people have these problems, so for example, the first one there, and as you might notice, you only need 2 points to say, okay, this is an LVO until we prove otherwise. Well, if your eyes are doing this gaze deviation thing, you get 2 points right there. And quickly, I'll explain the reason for that is because in order for me to look straight ahead, the input for that, or the signal for that, is coming from both sides of the front part of my brain. And they're kind of big areas called the frontal eye fields. And so for me to look straight ahead, each one is pushing equally against each other, so my eyes stay in the middle. If I want to look to my right, this one fires and this one relaxes. So now the signal is harder this way and my eyes go that way. So if I have a big stroke right here, this part is going to be off, right? It's not going to work at all. So this side is, as we say, unopposed. There's nothing pushing against it. And so now my eyes they're forced off this way. So my stroke is on the left, but my eyes are looking to the left. And if my stroke is on the left, my right side of my body, because these things crisscross, the right side of my body is going to be weak. So it looks as if I'm looking off at my normal side and I'm not even paying attention to this side. And I can't, no matter what, get my eyes to go back because I can't make this fire and push them the other way. As you can gather, that means that's a big stroke. And therefore, if people have this forced eye deviation, that automatically escalates them to the potential that they're having this LVO phenomenon. So that's the gist of it. So that's the way, and it'll come up in a second, why that's important in terms of how then we decide where to send people, right? So these are the scales, the things that the paramedics do in the field. Okay, so this is just to kind of summarize again real quick. We've got the anterior circulation, the posterior circulation, which is here and here, right? Again, anterior circulation and the posterior circulation, that's the same thing. And then you can have these LVOs that block the vessels at the bigger branches, right there in that basilar artery, here in the carotid, here in some of these, but they don't make it all the way up here because they're too big. So they take out big sections. The anterior circulation is the part that's doing our, like their face, arm, language, speech stuff. And the posterior circulation is doing our vision and our balance. So this is the BE of the B fast, and this is the FAS of the B fast. And the T for time is the whole thing. Okay? All right. So now, how do we move people around? How do we decide? So you call 911 and you're at home. And you say, you know, I'm having a stroke, or my dad's having a stroke, someone's having a stroke. So EMS comes to your house. So this is, again, this is the way it is pretty much around the country. In Cincinnati specifically, in all cities, these are designations that are given by the Heart Association. You have to show to them that you can meet certain things, have certain things in place, can do things in a certain amount of time, have all the proper resources in order to then qualify for any of these different titles. So the most basic one is an acute stroke ready hospital. Pretty much any emergency room, even a lot of urgent cares, would be considered acute stroke ready. That means that they have the TPA there. They can assess you, they can do a CAT scan, and they can give you the TPA if it's warranted. But that's all they can do. You immediately have to move. You have to go then to another hospital. They can't take care of the rest. A primary stroke center can do all that stuff, but they can keep you there. They have neurologists there, they have, but they can't do the big emergent stuff. But they can keep you there. Well, the last thing you want is to end up having one of these LVOs and be taken there. Because once they figure that out, now you've got to be taken there. And instead, they should have just gone straight there in the first place. So that's where that scale comes in to see, do we have enough signs when you see the patient to warrant them going to one of these hospitals. And these are called a thrombectomy capable stroke center and a comprehensive stroke center. Comprehensive is the topmost designation. That's the designation that can do all the stroke things as well as take care of the real bad bleeds, in particular the ruptured aneurysms. A thrombectomy capable stroke center can do everything when it comes to taking care of the clot that has blocked the vessel. Because a thrombectomy is what it's called when you go in and pull that LVO, pull that big clot out. And that's what's the newest in the last 4 or 5 years, that we have the capability to do that. So, Jewish Hospital is a thrombectomy capable stroke center. So if a person has a positive score in the field to suggest an LVO, then they can come to Jewish and we can address that. What we cannot do is the ruptured aneurysm part. But as I said at the beginning, that's a very different thing. The symptoms are very different. Ruptured aneurysms are usually very minimally mistaken for a stroke and then end up where they shouldn't be and then have to go to a comprehensive stroke center. So therefore, as we'll get to in a bit, so the 3 hospitals that are able to do the thrombectomies are us, University of Cincinnati, and Good Sam B. North. Good Sam and University of Cincinnati are comprehensive stroke centers. Jewish isn't yet. But again, as I said at the beginning, that's why I'm there, right? That's why I started this. They brought me over 2 years ago so we can build our program so that we can also become then a comprehensive stroke center.
So the UC hospital is the campus one then?
Yeah. Not the Westchester one.
Yeah, 'cause
No,
there's
it's
two different
downtown,
UC
yeah.
hospitals.
Correct, yeah. It's the UC.
UC.
Yes, correct. So, but the point is, for everything we've talked about so far, even the bleeds that aren't aneurysms, as a thrombectomy capable stroke center, we can do all that stuff. So, and what happens a lot, as you know, right across the street from Kenwood, the number of people, certainly around the holidays, that go in and out of that place, in and of itself is probably equal to a pretty good sized city, right? When you look at so the number of times where people will have these horrible symptoms, these LVO symptoms, in Kenwood, and literally are brought right across the street it's fantastic that we're that close, because we've had some amazing outcomes from people getting there fast enough. They're completely devastated. The person whose eyes are off here and they're not moving this side is also probably not talking, probably barely awake. They're going to be stuck like that unless we do something. And they will literally practically walk home out of there the next day if we have a really good success. And so that's why getting people to the right place, but see, at the same time, you can't just send every stroke to Good Sam or us or UC, because that's too much and they don't necessarily need that, right? So to try to triage them in this way is the system that the Heart Association recommends, and that's how we do it here in Cincinnati, and that's how it's done most of the country. Okay, so that's that. So what happens then once you get to the emergency room? I'll preface this by saying that the first part of this, the 0, 10, 15, 25 minutes right here, this is where we're working very hard to consolidate this down into 10 minutes. Because essentially what happens here is that, from the time the patient arrives, so 911 got called, EMS showed up, put you in the ambulance, drove you to the hospital, right? We've lost some time right there. So, but when they hit the door at 0 minutes, this part they're saying that this is Heart Association recommendations. That's where this comes from. Within 10 minutes, the doc should see you and make some assessment as to whether is this a stroke or not. Then within 15 minutes, they call the stroke team. Here it's the stroke team we know. In other places, it's within their own hospital, but they get everybody going. And then within 25 minutes, they're in the CAT scanner. I've spent a lot of time doing talks like this at firehouses with the EMS systems, because I want them, just like I want you. I went through those. Most of these slides are what I give to the paramedics, right? I've embellished them a little bit, assuming that people don't have that same level of medical knowledge. But the point is that I need them to know everything I just told you, because I need them to identify these posterior circulation strokes, and I need them to understand how important it is getting them there fast, because there's so much that we can do. So what we want them to be doing is that when they are at the house and they say, we have a stroke, I don't want them to hem and haw and be like, well, I don't know, maybe it's not, I'm not sure. Call the hospital, maybe we have a stroke, I don't really know, we're gonna bring them to you, you guys see what you think. Don't do that. Say, we have a stroke, these are the symptoms, I'm worried about a stroke, we are coming to you, we'll be there in 5 minutes. Because the hospital, Jewish and all the ERs around now, literally in the ER at Jewish, there is a button that whoever gets that phone call pushes the button and it activates the whole thing. The CAT scanner gets the patient off the table. The pharmacy starts getting the drugs ready in case they're going to give the TPA. The stroke team gets an alert that somebody's coming in, so they know to start pulling up the pictures on the computer. The ER doctor is like, oh, there's a stroke coming, and they get ready to see that patient. And so that the patients go literally from the ambulance right to the CAT scanner. Because literally these 25 minutes are not necessary. That should already be covered before they even get to the door. Because now, just within the last few months, we've had some what we call door to needle time, right? From the time you hit the door to the time the needle is injecting the TPA, of the whole thing, this whole thing that they say they want within 60 minutes, We've had times of 23 minutes, that's our fastest. Because you just got rid of all this. Because it's not necessary. So, anyway, the reason, incidentally, why do we do the CAT? Why is that the first thing? I'm having this big stroke, and the first thing you want to do is go get a CAT scan. Why don't you just give me the drug if that's what you think it is? Well, because as people know TPA as a clot buster. Well, the last thing you want to do is give a clot buster to someone who's got this. That's what blood looks like on a CAT scan, that big white ball. CAT scans are really, really, really sensitive at detecting blood. And so if you see that, you certainly do not want to give them a clot buster because that's just going to make that worse, right? So the first thing we do, and this is the way it's been since those TPA studies were done in the 80s. First thing you do is get a CAT scan. The CAT scan, ironically, in order to be eligible for TPA, has to be normal. Because a fresh stroke will not show up on a CAT scan. If it does, then that means your time frame is off. That means this happened a lot sooner than we thought it did. Because it takes time, 12 hours, 24 hours for the changes of a stroke to show up on a CAT scan. So if the CAT scan looks abnormal, immediately you have to start to second guess, wait, what's really going on here? Or how old is this stroke? And of course, if you see blood, then again, like I said, that's a whole different pathway. That's why I said the treatment for this is 180 of what it is for a stroke, where we give the clot buster, try to go in and get the clot out. For blood, those would be the worst things you could do, right? So that's why you get the CAT scan. What's new, and then just to finish this out, the other part is getting, the blood work. You need this blood work because we'll talk about this in a minute when we talk about who's eligible for TPA. You need to look at certain labs and things, but they can grab that literally as you're on your way to the CAT scanner, or even in the CAT scanner, or just getting out of the CAT scanner. So all this time can be really shaved down. And then, like we said, at 60 minutes is when they want you to ideally give the drug. So I keep talking about TPA, right, which stands for tissue plasminogen activator, also called alteplase. Well, we don't use it anymore. As of July, we now use tenecteplase, TNK. The differences here are really not important when it comes to day-to-day stuff, because the indications for giving it and the risks of giving it and all those things and the contraindications, or the reason you cannot give it, are all the same for the two drugs. Tenecteplase actually has been around longer than alteplase, longer than TPA. The studies they did in the 80s, though, they chose TPA. So that was the drug that got approved. That was the drug that everybody used because it works great. And so that's it. No one knew. Well, what about these other clot busters, right? What about all these? They might work. Tenecteplase was primarily used for heart attacks. Cardiac stuff, for same idea. Reperfuse, open up those blood vessels in the heart when someone's having a heart attack. The reason why they decided to even look at this is because tenecteplase has the advantage of being a powder in a vial. You shoot some saline in there and shake it up to reconstitute it, draw up the dose based on the person's weight, and you inject them with it and you're done. TPA, you have to still base it on weight, but then you give a certain percentage of it in the first 10 minutes as an IV drip, and then you drip the rest of it over an hour. And they have this IV bag hanging, and if you go back to my picture with the ambulances and where to go, if you're at the wrong hospital and we start the TPA and now you need to go to another hospital, now we need a nurse that has to go with you because the paramedics can't manage that medicine, and so, and that takes time. So the advantage of just being able to give the injection and shove them out the door is huge. It also just so happens that tenecteplase is cheaper. And all the studies that they've been doing, to confirm that this is still equally safe and as effective, actually have shown that it might be a little better. There might be a little lesser incidence of bleeding, and there might be better outcomes with it. That still is going to takes more time to really see if that's accurate, but it certainly is it's not unsafe. It's not any more harmful or riskier. So anyway, I put that in there just to tell you, if you hear TNK instead of TPA, it's because in July, the whole city, the stroke team, made the switch. And that's pretty much happening nationwide. So sooner than later, it's going to be TNK instead of TPA. Okay, so who's eligible? Well, as you can see, this is a paper from the Heart Association. Incidentally, most of those authors, especially the first ones here at the top, those are all UC neurologists. Some of them are not there any longer, but needless to say. So as my point before, UC still is at the forefront of stroke research, stroke care, looking at, and incidentally, I'll say one of the reasons they are is because since they touch so many stroke patients in 24-hour period, and certainly over a year, they have such a huge database of data because of how many stroke patients that they take care of. Therefore, they can do all kinds of studies to see who responds better to this and who responds better to that, and all these epidemiological studies. UC is, corners the market on that stuff. So anyway, this was from way back when they were looking at, again, this was alteplase, right, the TPA. But again, it all translates over for TNK, tenecteplase, as to who's eligible, what are the criteria. The thing is, the way to really look at it is in two ways: time, and then what risks do you have. The time part, so to answer your question, is that it used to be, it was 3 hours. Anything over 3 hours, when they did those original studies in the 80s and 90s, if you gave, no matter what the CAT scan looked like, if you gave TPA after 3 hours, your incidence of bleeding, meaning there was enough damage done that the brain would just bleed, your incidence of bleeding went way up after 3 hours. So as long as you could say that we know from the time the person was last known well to when we're going to give them the TPA was less than 3 hours, and the CAT scan looks okay, then you can get it. They kind of did some with additional studies and then pooling all that data together, what they call a meta-analysis, looking at a whole bunch of things, not just each individual study. They discovered that for the most part, up to 4.5 hours is actually reasonable outside some extenuating circumstances. They have to do with diabetes and renal failure and some of those other things that can be make a person maybe a little bit more risky outside of 3 hours. For the most part, we're pretty liberal about doing it up to 4.5 hours. So that was the time piece, but the other part, essentially, all the reasons you can't give somebody a clot buster, TPA, tenecteplase, all of it, is if they have some higher incidence of bleeding for some reason. So did you just have surgery? Probably not a good candidate. Are you already on a blood thinner, right? If you already have AFib and you're taking what everyone used to be on Coumadin or warfarin, or you're on some of these newer ones now, you can't get it because your blood's already thin, and now you have the risk of making it really thin and causing a worse problem than you started with. Things like aspirin, though, or Plavix, you might have heard of that one. These are all antiplatelet medicines, so they thin the blood in a different way. Those are okay. If you're on those, that risk of bleeding, that doesn't increase your risk of bleeding enough to make the benefit not worth it, right? So the likelihood of good benefit outweighs the risk, even on some aspirin. So essentially, there's all these things, and we look at the platelets to see, are your platelets really, really low, which means you're already at a high risk for bleeding. And so if those are too low, then we're not going to give it. So there's lots of different little criteria that this paper and the subsequent ones in the years that followed sort of outline. The one thing that is not in there as a risk for TNK or TPA is age. So it used to be that people thought that if you were maybe over 80, 90, not worth the risk. Well, the way they figured it out that it's probably okay to do, and now it is okay to do, is because if somebody who was 90 came in with a devastating stroke, and it was either they're going to be stuck that way, or we're going to make this last-ditch effort, and if it goes horribly, then, well, at least we tried. And those people did well. They were more likely to do well or not improve, and much less likely to get worse. So the age thing was taken out. So age is not an issue when it comes to TPA or TNK. Okay, so back to this picture on the right side at least. This one here on the left though is looking, when they do the CAT scans now, in addition to doing just the plain CAT scan, like I showed you that picture, that one had blood on it, we also do what's called a CT angiogram, a CTA. What we're looking at here is from the feet up. So we're looking, so this person's laying like this, their right side is over there, their left side is over here, and we're looking straight up. And essentially, this right here, because it's kind of coming right at us, is this basilar artery. And these two things are the branches coming off of it. And this all goes to the posterior circulation. And then right here, coming straight at us, are the carotid arteries that are then branching off this way. You can see it to this big branch that feeds this hemisphere. But over here, the circle certainly helps point out where the problem is. But you can definitely see that there's no blood flow right past there. That's an LVO. Essentially, that's an LVO right here because it is blocking all this. But you can see this flow going up to the top. That's still there. But this is gone. So and now you can see too faintly all this. Now it's faint on this side too, but definitely fainter. That's that collateral circulation that we talked about at the very beginning. That's feeding the penumbra, the area that's still not dead, but salvageable. And the symptoms that this person is having are probably the symptoms involving all of this brain. So that's what now we do these CAT scan angiograms, these CT angiograms right at the same time. And if we see an LVO, then we know that's the path that we need to take. This was just to sort of reiterate the same thing. There's our penumbra. Anyway. Okay, so now back to this picture, this CT perfusion. So if we see that LVO, we stick them back in the CAT scanner, give a different set of contrast, and now we look again at this picture. What we're looking for, again, the purple is the area where the brain is already dead, that's the core, and the green is the salvageable part, the penumbra. So what we're looking for is what is the difference mathematically, literally, what is the mathematical difference? So as you can see down here at the bottom, it says that the cerebral blood flow that's less than 30% volume is 46 milliliters. What that means is that the brain here in purple is getting less than 30% of its needed blood volume. And we know that that's incompatible with it surviving. And this part is telling us that the maximum amount rate that the blood is flowing through here is greater than 6 seconds. It should be less than 6 seconds. If it's greater than 6 seconds, that means it's not flowing fast enough, and that means that's the part that's at risk then of dying. And so they literally subtract the two parts to say how much is salvageable. And in this particular case, the mismatch is 65 milliliters, which means that there's 65 milliliters of brain here that is at risk and 46 milliliters that's dead. And if we wait any longer, that number is going to get smaller and that one's going to get bigger. And so if the proportion makes sense, then they say, okay, it's worth going in there and pulling that clot out. If it's almost 1-to-1, then they won't do it, because at that point, there's nothing to salvage. If you pull the clot out, all that much brain is already lost, and all you're going to get is the risk of going in there and no benefit at all. So how do we coordinate all this? Welcome technology. So there's this outfit called Viz.ai, and it is pretty much used, I would say, almost nationwide at this point. Certainly used here in Cincinnati. Essentially, on our phones, we get the computer will analyze that CTA picture. If it sees that LVO sign on the CAT scan, then it immediately sends out an alert before the radiologist even has the pictures. They know it's coming, right? Because they hit that button, activated the stroke team, so they know to look. But as soon as the computer says, I think that's an LVO, then we all get pings on our phone. And by all, I mean me, I mean our neurosurgeons, who are the ones that are going to go in and pull that clot out, the stroke team, the pharmacy, the ER, everybody gets an alert. The people who are on call for the cath lab, the lab that does the catheterization, who may not be in the building, they all start coming in, like everything gets going as soon as this AI identifies that there's this LVO. So that's what this is sort of representing. So there's a CTA, we can look at that, I can look at it on my phone. The resolution is actually better than it is on the computer monitor in the hospital because it's our phone screens are so high res. And just with my finger, I can scroll through all the pictures and I can see the LVO myself. I can see the CAT scan. Now the funny thing is that they need to change their picture because that's hemorrhage. So you can't do any of what this is suggesting if that's really their CAT scan, but now you know. So anyway, I can see the CAT scan, and then I can see the CTP, and then this over here is now it's all HIPAA compliant. Now we're texting each other. The neurosurgeon will say, yeah, I see that. What's the exam? The stroke team doc and the ER doc will text back like, this is how old they are. This is their baseline deficits, where they're starting from. This is what I see now. This is when it started. This is, and then the interventionist will say, okay, like in our, send them over to Jewish. We'll do it. And they'll helicopter them if they are, didn't start out at Jewish, or if they're at Jewish, then off they go. And this has saved, it's saved lots of lives. Certainly, and as I said, stroke doesn't kill you, right? So it's saved a lot of what we call morbidity, not mortality, which is, in my opinion, worse, right? Sometimes, I would rather just die than be stuck with that stuff. So it has really made a huge impact on morbidity of stroke, like just this one little app. So that's how everything gets coordinated. And essentially, this is what they're doing. So these are all cartoon drawings, obviously. So when they do a catheterization of any kind, whether it be a cardiac cath